So I'll just get started because I'm the one who's late. My name is Olivia. I'm a third year medical student at the University of Iowa, Carver College of Medicine. I've done several of these in the past, so welcome back to those of you who have been with me before, and welcome to those of you who it's your first time. We have a lot of fun, I think, and it's really great if we all participate and respond to questions, whether it's in the chat or if you unmute yourself, any way that you're comfortable with. And today we're going to be talking about a pediatrics topic. The last one that I did was neonatal physiology, and a lot of people really liked learning about a pediatrics topic. So today we're going to do another very common pediatric presentation, which is respiratory infections. So as always, we're going to start with a simulated patient case, and that will include a physical exam and a differential diagnosis and our assessment and plan. So those will all kind of be the components of the SOAP note, which should be in the chat. If you're having trouble accessing it or have any questions, then you can let me know and I can repost the link. And then the second part will be a lesson on the pathology of the disease. So if you'd like to get that certificate of completion, then feel free to fill out the quiz at the end. And if you get over 80%, then you can get that. And it's not supposed to be like a high stakes thing. If you have questions about the quiz at the end, then we can always go back to the previous slides and work through them together. So here's what it looks like. Again, if you have any issues with that, please let me know. Today, we have a 3-year-old boy who is brought to the emergency room by his father at 3 a.m. with a chief complaint of a cough. So without any additional information, maybe pretend you're having a busy night and you just see this pop up on the status board. What are some things that run through your brain of what could be causing a cough in a kid like this?
Maybe asthma or bronchitis, history of?
Absolutely. Asthma is super common in kids, can be worse at night. So that's a great thought. What else do we have?
Allergies, maybe, or any previous medications taken.
A few things in the chat, the flu, choking, or airway obstructions. So those are great ways of thinking about it as well.
Pneumonia, trachea or esophageal rupture.
Yeah, absolutely. I'd say like the rupture is probably like the most serious out of all of those. And would probably have some other things like bleeding, coughing up blood. They might also be dead at that point. But yeah, we want to keep our differential super broad at the beginning and then narrow it as we go, as we get more information. So those are some great initial thoughts, and we'll kind of add on to that with some additional history here. So we just kind of covered a lot of these, and this is not an exhaustive list at all. But people said the flu or some other viral infections that are listed here. Chronic diseases like allergies and asthma were brought up. Also some environmental things like a foreign body aspiration, which can be like choking, the object falls down into your airway. And then some other bacterial infections as well. So yeah, you guys did a great job with kind of thinking through the different etiologies before we go and see this patient. And then just for kicks, does anybody know what pertussis is? Like the common name for it? Andrew said whooping cough, exactly.
Yeah, I was going to say that, whooping cough.
Yeah, so it's whooping cough. That's just the bacterial name. And again, that's something that we would for sure not want to miss. Because pertussis can be pretty serious, or anything on this list is serious, but these bacterial ones especially can really be nasty. So going more into our case, this is the history of present illness. So this is great information for the subjective part of the note. So we find out that this cough began 1 day ago, and overnight, so this is like 3 a.m. at nighttime, it's gotten a lot worse. And this patient, who's only 3 years old, when we ask him like, hey, does anything hurt? He points to his throat. He's not really wanting to chat with us, which is pretty normal in kids. His father, who brought him in, describes the cough as sounding like a seal barking. And it sounds like he's also had this intermittent cough with wheezing before, but specifically when playing outside in the snow or being around cats. But that's not the same as the cough that he's experiencing right now. So that's another thing that we'd want to consider. It sounds like this process might be a little bit different from that. And the way that this is sort of started and progressed in this shorter time frame, we want to address this first and then maybe keep those other symptoms in the back of our mind for later on. So for our review of systems, which is just kind of like a quick head to toe scan of other pertinent things that aren't the cough that could be related to it, it sounds like our patient has had a fever for the last 2 days. He's been feeling fatigued and tired. He's also had this nasal drainage and sore throat. So the picture of that really is kind of screaming viral illness to me. But you know, if it's his cough is bad enough to bring him into the ER at night, there's some things that we'd want to rule out as well. And then for the review of systems, it's also negative for wheezing right now and no phlegm production. So that could maybe point us away from something like asthma or like a bacterial pneumonia, because those might be more those symptoms might be more associated with it. And it sounds like he's not experiencing those. So moving on to some additional history that's not, you know, just more general patient information and not specific to this acute illness. For his past medical history, he was born via C-section and he was full term, so he was not a premature baby. He does have allergies to peanuts specifically. And then his parents also say that he is up to date on all vaccinations. That's a very important part of history that we like to double check in pediatric patients. For his family history, his older sister, who's 7 years old, has a history of asthma. Again, we'd want to maybe consider that in thinking about what's a more chronic process that could be related to this, but to also keep our eyes open for something that's more acute. And then his mother, who's 36 years old, has type 1 diabetes. His surgical and procedural history is pretty short. He just had a circumcision at birth. And for his social history, their family recently moved to the area about 3 months ago. He attends a daycare 5 days a week. So probably around a lot of other kids who, you know, they get sick. They get each other sick very frequently. And then he also loves Legos, maybe something to bond with him over, and possibly a thing to consider that if he did have a history of playing with really small objects, that there's a chance that he could have choked on one and aspirated. So any piece of information you can get from the patient, I think is valuable in some way. Okay, so this is moving into the objective portion of the note. We always start with the vitals, and I just want to remind you guys that if you're familiar with the normal ranges for adult vitals, that kids have a little bit different set of what's normal. So for his blood pressure, which is 100/71, that might seem a little low for the adult side of things, but this is a totally normal blood pressure for a 3-year-old. His heart rate is 88, so that's normal. His respirations are 26. So even for kids who breathe faster than adults, this might be a little bit borderline high or on the upper limit of normal, but it's still not like super red flag that he's breathing like super fast. His temperature, he's got a 37.3 degrees Celsius reading on the thermometer, which I don't know exactly what that is in Fahrenheit, but we wouldn't consider it to be a true fever until it's over 38. And then lastly, his oxygen saturation, that's the percent oxygen in his blood, that's 97%. And that's a comfortable number that we want to, we'll keep an eye closely on all of these vitals, because kids, although they can look really good on paper, they also can deteriorate really quickly. So it can get scary really fast. And so we always want to have a sort of like healthy skepticism in somebody who might clinically, just looking at them, look really sick, but then their vitals look like they're okay. You want to kind of use that clinical reasoning to determine how they're doing. Next, into the physical exam. So just a couple highlights here. he's not happy. It's 3 a.m. and he's in the ER. So he's crying. He's laying supine. Does anybody know like what position that is? Supine.
Laying on his back?
Yeah, exactly. Laying on his back. So he is preferring to be reclined versus sitting up or maybe being on the lap of his parent. And he's also not really cooperative with the exam. So this information. Yeah, what's up?
Isn't that also preferred like method for a patient that's coming in with any type of like respiration, like distress or anything, laying supine?
Yeah, that's a great point. So we'll go through a couple different postures that are associated with like respiratory distress. And this can be one for a specific thing that we'll talk about, I think in a couple slides, that is a preferred posture for breathing. There's one other one that we'll talk about that's very also characteristic of a different disease process. But you're totally right. In some cases, when they lay on their back, they're better able to use their accessory muscles of respiration to help move air in and out of their lungs. So that's a great point. For his head and neck exam, which the HEENT stands for head, ears, eyes, nose, and throat. His tympanic membranes or his eardrums are normal, so it doesn't look like he has an ear infection. He does have erythema of the throat, and erythema is the medical word for redness. So no like pus or exudates, it looks like, so not concerning for something like strep throat, but just some like mild redness. Then he also has this trace bilateral clear nasal discharge. So that's just like a little bit leftover runny nose. Could be a lot of things causing that. And he's also not drooling. I just put that in for a pertinent negative on exam that we'll talk about a little bit more later in the pathology section. But it looks like, yeah, he's doing okay from a head and neck perspective. For his cardiac exam, it's pretty much completely unremarkable. He has a regular rhythm with no murmurs. His pulmonary exam is probably the most interesting and significant of his physical exam. So the first thing we notice is that he's got this inspiratory stridor. And rather than explaining, I have a video that I'll show before we move on to the next slide. That's present at rest. And then he also has no retractions or nasal flaring. And the reason I put these in is that those can be signs of like more severe respiratory distress that we'd want to look for in kids who can't otherwise communicate that they're having trouble breathing. And then for his abdominal and extremities, again, those are unremarkable. We're looking at his extremities and we see that he does not have any cyanosis, and that's when your like fingertips or your lips might turn a bluish color if you're not getting enough oxygen in your bloodstream. So it's good that he does not have that. I'm going to play this video now. Let me know if you guys are having trouble with hearing it at all. And hopefully I can get it to work. So that's the cough that we were talking about, the kind of barkiness. And then you'll notice when he's breathing in, he's kind of making like a gasping sound a little bit. I'm going to skip ahead and it might be a little bit more noticeable. Okay. I think that's pretty sufficient for demonstrating what stridor looks like. It can be really scary to a parent who hasn't dealt with this before. And yeah, also uncomfortable for the kiddo. So that's just, again, a more noticeable change in breathing during the inspiration or when you're taking a breath in, and less so when they're exhaling, is the finding that we're seeing here. Sorry, moving to the next slide here. Okay, so for our differential diagnosis, I wanted to go through 3 different respiratory pathologies that we would want to include in our differential. So the number one that we're thinking of right now is something called croup. And the long medical name for it is laryngotracheobronchitis, meaning that there's sort of this diffuse inflammation all the way from the larynx down the trachea and into the bronchi. But the normal way to just say it is croup. It's shorter and easier. So the most common pathogen that causes croup is the para-influenza virus. We'll talk about like the different viruses and things a little bit later. And there are other things that can cause croup, but this is just the most common one. And as we heard in the history and observed a little bit in the video from the exam, there's this very characteristic barking cough that tends to get worse at night and is preceded by cold-like symptoms that maybe are around for a day or so. And then the cold symptoms tend to get better, but then the cough itself ends up getting worse. So that's croup. The second thing that we want to look out for is something called bacterial epiglottitis. This is a very serious and potentially life-threatening respiratory infection that we suspect highly in kids who have not gotten routine vaccinations, especially to a bacteria called Haemophilus influenza. A little bit confusing because there's an influenza virus and this is a bacteria, so don't get too confused with that. This is again, a bacterial infection, so it's going to affect a more local structure called the epiglottis, and we'll go through the anatomy a little bit later. And some red flags on physical exam for this would be things like tripoding, which is another posture that's sometimes preferred in this type of disease. And that's kind of where they might be sitting upright and then leaning forward with their hands, like bracing their knees or like the bed, and then kind of extending their neck out so that they are in like a sniffing position almost. That's called tripoding. And I have a picture of it on another slide. I probably should have put it here, but whatever. And because it's bacterial and not viral, we would also expect to see a high fever with this and not a low fever. So this is an airway emergency, and we'll talk about the treatment for it a little bit later, but this is definitely the most severe thing that we would be potentially worried about in this patient. And then the last thing, that's a very, very common illness, and you probably have heard of it before in kids, is called RSV. And the actual pathologic process that happens is called bronchiolitis, which is inflammation of the bronchioles, or the really small distal airways that are lower down in the lungs. So unlike the other two, which are an upper respiratory infection, this is a lower respiratory infection that kind of behaves more like pneumonia, but it's caused by a virus. And the key feature here is that unlike croup, which you have the inspiratory stridor, RSV is going to present with expiratory wheezing. So that's going to sound a lot more like an asthma type wheeze versus the sort of like gasping sound. So that's our differential. I know we've gone through a lot of information, but I think as we continue to progress, things will kind of revisit some of these concepts and they'll be a little bit more thoroughly explained. I just wanted to check and see if anybody had questions, if we need to go back at all, and if I'm moving at a pace that's comfortable for you guys, because I can certainly slow down or speed up if you'd like. Yeah, I can go back to the last slide.
Could you talk a little bit more about croup versus regular RSV bronchiolitis?
Yeah, absolutely. So basically it's more so the part of the airway that's affected. They're both caused by viruses, and they're both a sort of milder form of inflammation compared to a bacterial cause. The difference is that croup is going to be much higher up in the airway. And so that stridor and the barking cough is really caused by an inflammation around the voice box. And you kind of get this narrowing of the airway there's a couple pictures that I think will help as well. And then with RSV, again, it's going to settle deeper down in the lungs. So instead of having those like more sharp and harsh sounds, you get these like diffuse wheezes, and it just tends to be, I don't know how else to explain it. I guess it's more common epidemiologically, but the presentation really is upper versus lower airway.
Okay.
And
then is RSV more of like a hereditary form, or could just be something that babies are born with, or?
No, so that's a great point. So these are all going to be infectious etiology. So these are things that you acquire through pathogens like viruses and bacteria. RSV is it's kind of like a common cold or the flu or something that you would acquire through droplet transmission in the community and would go away. It will always resolve. It's never a chronic thing. And you can, yeah, it just depends on the individual patient, how severe their illness is. It could be as simple as like a cold, and some patients end up needing to be hospitalized for it. So yeah.
I'm confused between that and bronchitis. That's probably why.
Gotcha. Yes. Yeah. Bronchiolitis and bronchitis sound very similar. And again, those are non-specific things. Those are just the pathologic process. So anything that ends in itis is going to mean inflammation of that thing. And then the thing that comes before the itis is describing the anatomic location. And a lot of things can cause inflammation, like asthma. So you can have like a superimposed asthma with bronchitis or COPD with bronchitis. But this is specifically a viral or an infectious etiology.
Thank you.
Absolutely. Yeah. Thank you for clarifying on that. Okay. So if we want to come to a diagnosis, what are your guys' thoughts on the types of tests that we should order?
X-ray, CT maybe, or
Yeah, I like X-ray a lot. Mm-hmm. What
blood
other?
work, CBC.
Yeah, CBC could be
Yeah.
helpful. Mm-hmm.
And a WBC, like a white blood cell count.
Yeah, that's absolutely right. So that's included in a CBC, but that's one of the most important parts that we look for,
Okay.
especially in somebody that we suspect an infection, because then we can confirm that they're experiencing an infection.
Okay.
Great work. Yeah. So some other things, just brief note. So the CBC and the BMP, I feel like we all kind of shoot for those first because they're super easy, they're inexpensive, and they can give you good information. In this patient, we know that they probably have an infection of some sort. And so it wouldn't necessarily be treatment guiding, but they're not wrong answers. Like, don't get me wrong, that probably if this patient was in the ER, that would be on the list of things that they order. The things that might be more specific for teasing out which diagnosis on our differential is the correct one, things like an X-ray, other imaging like a video laryngoscopy, which is, I would say, not actually done very often, but it's like inserting a little kind of like microscopic camera that's on this like cord that they put down your nose. Yeah, and it just sits kind of right in your airway. So it doesn't cross your vocal cords and go all the way down to your lungs, but it gives you a really nice visual of the airway above the vocal cords. And so that can be used. And I have a video in here to show you guys what that would look like in a couple of slides. But the X-ray, I would say, is one really good idea. And then for microbiology studies, we can do things like a respiratory viral panel to see exactly what virus is causing their illness. And then to be extra sure that they don't have anything super life-threatening, we can do blood cultures and like a throat gram stain and culture with that to see if they do have a bacterial cause, which again would be something that we're more concerned about than a virus. Someone is asking if the video would always be used if there's an airway problem. So that just kind of depends on your clinical judgment. I think that if, having a direct video to visualize the airway is a really important piece in ruling out something that could be life-threatening if you suspect something in the airway. But for a patient like this, where we're pretty sure it's viral because of the physical exam and the vitals and the history that we've gotten, then it's not 100% necessary. It just might be a good tool if you're needing to rule something else out. Great question. So here's the results from our studies. We did get an X-ray. The first thing that I want to draw your guys' attention to is I have a couple of views here. So this first one is showing a lateral view. So it's like the patient is sitting kind of facing to the side and it's doing a cross section through like the midline. And so that's the first view. And then the second view is them looking at you. So you're looking straight on. And that's why you can see like both lungs and all of that. The thing here that we're looking at is something called a steeple sign. And it's pointed out with the arrows, but I don't think that's really a great view of it. I think you can see it better in the second picture, which is the like straight on view. And you see this darker spot or this darker line that runs down kind of in between the lungs. And as you go upwards, it kind of tapers to this point, almost like a church steeple. And that's the steeple sign. And that's actually the airway. And this up here where it starts to taper off is up by the voice box or the larynx. And that's just all kind of like swollen tissue. And it looks really scary, like, oh my gosh, their airway is completely closed off. But you just have to remember that it's enclosed by a lot of other soft tissue. And so it's not like a complete obstruction, but it is something that is very highly associated with croup specifically. And then we also, just for funsies, did a respiratory viral panel, and it did come back positive for para-influenza type 3. So if you remember back on the differential slide, we said that para-influenza is the most common pathogen that causes croup. So with this, plus the barky cough, plus well, I'll just read the assessment. So we have our 3-year-old previously healthy male who presented to the ER with a 1-day history of that barky cough that acutely worsened overnight. And he had this sort of cold picture before with nasal drainage and fever that's improved in the last day. On exam, we saw inspiratory stridor and signs of like mild respiratory distress because of the stridor and because he was having like some other difficulties with breathing. The x-ray showed a narrowing of the airway at the level of the larynx. That's the steeple sign. And the respiratory panel was positive for parainfluenza. So all of this together is consistent with a diagnosis of croup, AKA laryngotracheobronchitis. I know that's a lot of information, but hopefully that's a nice summary of all the things that we've done so far and kind of putting everything together. So that part, you don't have to type it in word for word. You can just say like any synthesis in your own words or a quick summary of that in your assessment portion of the note. But it's really just trying to pull together a couple of things and explain why you think that it's croup. So for us, we're including our physical exam, we're including our lab findings, we're including parts of the history, and we're saying like this is all consistent with croup. So for our plan, it's like early in the morning / in the middle of the night. We're going to keep this kiddo here and admit him overnight, at least until the morning, for further observation and treatment. And the 2 things for treatment that we're going to be able to offer him is something called nebulized racemic epinephrine. If you've taken organic chemistry, I think you probably learn about like a racemic mixture and isomers and things like that. So this is like having both isomers of epinephrine. And I think I've forgotten everything beyond that. So if you have specific questions about the chemistry, please don't ask me. And then if you're familiar with a nebulizer, it's more commonly used, I'd say, with albuterol in people with asthma. And it's just a way of making a liquid medication be aerosolized and able to just be inhaled. And I have a picture of that coming up too. And then the other thing that we're going to do is a shot of dexamethasone intramuscularly. So that's just giving a shot like regular, like what you'd get for a flu shot or something in your arm or in your glute or in your thigh. For kids, it's usually the thigh or the glute. And dexamethasone is a type of corticosteroid. So one that's probably a little bit more common that people hear of is prednisone. But maybe with COVID, like because we give dexamethasone to COVID patients, you might have heard that as well. And the function of steroids is to just reduce inflammation in the body. So again, we're going to kind of go over this again at the very end when we're talking through the pathology and everything. But this can be, I guess, what you put in your plan section of the note. Okay. How are we doing, guys? Do we have any questions? Anything that we want to change with the pace? I'm just going to keep going. And if you want to stop me or ask to slow down or go back at all, just let me know. Okay. All right, so as promised, we're gonna do a little bit of anatomy. This is specifically looking at the airway. This is kind of on this left picture with the child. We see the full scope of the airway from the nose and the mouth, which is the start of it, all the way down to the lungs. So air will enter in either through the sinuses or the mouth. Most people breathe through their nose. And it passes through the sinuses down into something called the pharynx. And the pharynx is kind of the back of the throat in your like mouth and nose region. So that's a lot of soft tissue. If you ever have like postnasal drip, then that can cause like a pharyngeal irritation, or like a pharyngitis or something like that. And then the larynx lies right below that, and that's your voice box. So you can feel it on yourself if you're talking. It's the thing that vibrates, and you can also feel the cartilage that sits over your larynx. That's called the thyroid cartilage, and that's kind of like the Adam's apple, if you know it as that instead. So that's the larynx, and that's the thing that we're concerned about here with croup. Moving down further, so the air will enter the larynx, and this is also where your vocal cords are, which is where you get that vibration. And I want to move us over to this other picture on the right here. So that's a cross section going right through the larynx. And the one thing that I want you to pay attention to is this thing that kind of looks like a mustache, I suppose, that's colored light pink, and that's called the epiglottis. And the epiglottis is very important because it helps to protect your airway from fluids when you're eating and drinking, so that you don't have things going down into your lungs when you're supposed to get them into your esophagus. So if you remember the epiglottitis, this is the thing that would be inflamed or like infected with bacteria. And you can imagine if that is really swollen and inflamed, then you can obstruct your airway with it, which is why we're so concerned if there's epiglottitis. So don't worry so much about the whole like median glossoepiglottic fold. That's not the point of this. I just wanted you guys to be able to see where the epiglottis is and how like it relates to this other illustration. So the airway continues down after you pass the vocal cords, you get into the trachea, and you can, on this right picture, also see these little like darker gray stripes that are going through it. Those are the rings of cartilage that go around the trachea to keep it open, and you can't compress it into like a flat thing. You want to keep your airway open all the time. So that's why you've got cartilage going around. Yeah, what's that?
Just because when I scrub sometimes, and I know anesthesiologist was telling us about that, I didn't know that was a thing for it. But is that where they intubate from, or like whether you have to intubate the patient?
Yeah, this is actually the exact view that they use when you intubate a patient. Is you use the laryngoscope. That's the little blade thing that you use to help like see where you're putting the tube into, and the tube is going to pass right in through these vocal cords, which are the white stripes. And that's exactly the landmarks that you're looking for. You want to have a clear view of the epiglottis. Right underneath the epiglottis are going to be your cords, and that's exactly where you pass the tube through. So that's a great observation.
Thank you.
Yeah. And then just to complete the tour of the airway, once you get into the trachea, we go down, 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 and it branches into your two bronchi. And from there, it just branches into the rest of the bronchial tree. And the bronchioles are the very tiny, tiny, tiny airways after we branch and branch and branch, right before we get to the air sacs or the alveoli. So if you think of it as a tree, like that grows out of the ground, you've got your trunk, which is the trachea, and your bronchi, which are like the main branches, and then your bronchioles are more like the little twigs that come off of the branches. Okay. There is a question. Would you have to do anything different with treating croup as it pertains to COVID-19 in recent studies? I think from my knowledge, I guess I'm not sure if you're asking if you are superimposed, like if you have croup and COVID at the same time, or if you're not sure yet if it is COVID versus croup. But I think like, number one, you always want to protect their airway. So if they're ever at risk of having any sort of respiratory compromise, then you want to consider intubation or just doing something to secure the airway. providing extra oxygen, doing things to help minimize swelling and inflammation, like giving steroids, would be all, I'd say, like steps that cover both viruses. But I'm not sure if there's any additional overlap. I don't think it's wrong to give, like, what's the new antiviral that they're using for COVID? I can't even remember, but like remdesivir has been used in the past. I'm not sure if it's still like recommended clinical practice or not, because I'll be honest, I just took step 1 recently, so I've been a little behind on the clinical guidelines for that, but I don't think it would be wrong to give those. It just wouldn't actually do anything for croup because it's a different virus.
Do you mind if I piggyback on the question really quickly?
Yeah, go for it.
About protecting the airway. At what point are we looking at the vitals to figure out when we need to protect? Like, are they satting less than like 79, 80? Then you're like, okay, we need to intubate. Or are you looking at the BP, everything in the big picture? Or
yes, exactly. So we're kind of pulling everything together. We're looking at their SATs, if their oxygen levels are really low, like below 90, then we start to get worried about, okay, we need to give them supplemental oxygen. If the oxygen, like through a nasal cannula or through an oxygen mask, isn't working, what's the reason for why it's not actually working? Like, is it because their airway is getting like closed up and we need to make sure that there's a tube that keeps it open? Is it because the air is getting into the lungs, but then it can't actually get into your blood vessels? That's like in COVID when you've got so much like inflammation, or in pneumonia also, you've got so much inflammation and like literal fluid in your lungs that's blocking the air from diffusing into the bloodstream. Like that would be a different cause, but still potentially warranting intubation because you're able to better control the oxygen flow and keep the airways open and stuff. So it's kind of a clinical decision that you make. There's no like special algorithm for it, but especially in cases where you're like the epiglottitis, for example, that's like priority number 1. You want to make sure you've got a secure airway. I actually am planning on doing another virtual rounds in the next couple months, specifically talking about airway management, as it's a pretty big like anesthesia topic, and I'm interested in anesthesia. So we can talk about that in more detail later, but that's kind of the recap of how you decide to intubate or do other airway management, is by, looking at their oxygen, but then also like looking at the clinical picture.
Thank you. I want to go into emergency, so thank you.
Yeah, no problem. Thanks for asking. Okay, so this is just highlighting again, like the different things that we're looking at. The epiglottitis is obviously affecting the epiglottis. I circled this in yellow here. Croup, as we said before, it's going to kind of affect the larynx, the trachea, and possibly also the main bronchi. So this whole thing anywhere could be affected. It doesn't have to be the whole trachea. It could be limited to just the larynx, or it could be a little bit more broad than that. But the point is that it's upper airway. And then RSV, as we said before, is going to affect those more distal bronchioles, which are the twigs on the tree. So they're going to be a lot further down, and they're going to be more of a lower respiratory picture. Okay, I also just wanted to make this point really quick because somebody had brought up choking earlier, and I think that is a very important thing to consider in young children. So just this might come in handy at some point in like your medical school or anatomy class or something, but not as much for this case. So your trachea is just 1 tube, but then your bronchi are 2 tubes. So that's where the trachea branches off into 2. And a fun fact is that your right mainstem bronchus, which is this one over here, is ever slightly more wide and vertical than the left one, which kind of comes off at more of an angle and it's more narrow. So it's more likely that if you were to aspirate something like a Lego or a peanut, or I don't know what else kids put in their mouth, a tooth even, I think this x-ray here, this is a baby tooth that somebody, it got into their trachea, or it bypassed the epiglottis, fell down the vocal cords, and then instead of landing just at the trachea, because it splits down into 2, it went into the right mainstem bronchus. So that's just a little fun fact that it's more likely to go into the right side. Okay, getting to the pathology now. I think we're on the home stretch. So again, I hope this isn't too overwhelming, but we're going to go with croup first, which is what our patient actually has. So as I said before, it's a para-influenza virus. So as the name implies, it's very similar to the actual influenza virus that would cause like the flu that we know and love. So don't worry about the actual structure of this virus. I just wanted to show you guys what it looks like, kind of a placeholder for some color and make it more interesting. But that's what the parainfluenza virus looks like. It is very commonly spread in schools and in daycare, anywhere that people are in like close contact with each other, and kids are always like coughing and sneezing and putting their hands in their mouth and then touching things. So it's very easy to get these types of viruses in those environments. And there is a couple classic signs. So classically, it's worse at night, which is like what our patient had. They can actually look pretty good during the day. Like you go to the doctor during the daytime, maybe it's the morning, and they're like have been having this cold like thing, but they're starting to get a barky cough. And the doctor is like, well, it doesn't actually look that bad, but it can get really like not so much dangerous, but just extremely uncomfortable and scary for both the kid and the parent when their kid goes home and tries to go to sleep at night and they're just coughing. And yeah, so that's why we like to associate this with being worse at night. There's also this thing called the prodrome. This is not specific to croup, but like any virus or any viral illness can have something called a prodrome, which is like a pre-illness. I don't really know how else to explain it, but you have these additional symptoms that aren't present through the duration of your illness that just are there for a few days or for a little while, and then those go away. And then that's when you start to have like the quote real symptoms of what the illness is. So for this thing, like if you start off with a cold and just like a runny nose and maybe a low fever, that's not necessarily how it's going to be for the rest of the illness. That can go away, and then it takes over with having that inspiratory stridor and the barky cough.
Can I ask a good question?
Yeah, please
Sorry.
do.
I'm so sorry, but just going on prodrome, because I was recently in a hospital with COVID. We found out it was COVID later. With the symptoms I was presenting with, I guess it didn't catch up, but my CBC showed like certain like, okay, yeah, he's at risk for some type of infection. Some infection. It was like, I guess like in the phase of happening. Would that be where like the CBC shows like, okay, hey, yeah, his blood work shows he's fighting some infection, but we haven't found out what it is. And like 2-3 days later, it actually was like, okay, hey, come back and this is what it is.
Yeah. So that's really interesting. I think like I'm not sure in the definition of prodrome. That's like can be your clinical signs or symptoms, but yeah, there's certainly the possibility that your actual objective and laboratory data will reflect something before you start personally experiencing it. Like, I suppose if people tested with a PCR for COVID and it came back positive, but it was like their pre-symptomatic phase, it's kind of the same idea where your body's like starting to experience it and it's responding, but it's not severe enough that you are experiencing the symptoms.
Okay.
So yeah, I think that you're thinking the right way. And then for the pathology of the symptoms here, so pretty much the immune response to clearing a virus is virtually the same for every virus. You get like your T cells and stuff that are going in. And the way you get inflammation is the blood vessels that are supplying the area with the infection are going to really dilate a lot. That leaks a lot of fluid out and causes that swelling and edema. To help get those immune cells out of the circulation and into the tissues to fight off the viruses where it's needed. So you get this swelling of the airway, which it's not like, I don't want it to sound like it's some sort of like an anaphylactic swelling where your airway is going to be like completely closed off. This is more just like, I don't know, like if you had twisted your ankle and you just sort of get this global, just like redness and warmth and enlargement of the tissue, but it's not like, oh my gosh, you're going to die. So that's what causes that steeple sign on the x-ray. And you get that narrowing that causes the stridor and then the barky cough as well. So I don't think that it's super important to know the exact mechanism, but just to know kind of the overall, like the blood vessels are going to start to dilate. You get that leaky fluid. And the reason that's important is because that's one of the targets for treatment with that racemic epinephrine that we talked about before. That's going to help counteract that. And so, and I'll show a picture of that later too. So moving on to RSV, which is one of the most common viral illnesses in all kids. Almost every kid gets RSV at some point in their life, and it just depends on like how immunocompetent they are and how severe the illness is that determines their treatment. So for RSV, the pathology for this, I took a slide from University of Utah's website, and it shows this very interesting, like sort of giant looking cell with all these little spots in it. And that's actually used to be multiple cells of the airway or of the epithelium that lines the airway. So that's like the surface level of cells. And those fuse together into this giant multinucleated cell. So it looks like it's one cell that's way bigger than the rest of the ones that are around it, but it used to actually be multiple ones, and now it just has all these nuclei. So I don't know the like clinical significance of this or why that happens, like the mechanism for why they fuse together. But this is just something that like, if you were to take a biopsy, which in a live patient you never would, this is just like what you would see under the microscope. So kind of interesting. I don't know. And then RSV, like we said before, it causes bronchiolitis. That's inflammation of the bronchioles, which are the very ends of the airway, kind of the twigs of the tree. And so that's the lower respiratory tract. And because of that, you're going to get this more expiratory wheezing rather than the inspiratory stridor. And right now, we currently don't have a vaccine against RSV, but we are working on one. So hopefully in the near future, we can protect kids from another viral illness that causes a lot of, parents to miss work and hospitalizations and drugs and treatment and all that sort of stuff. We can try to save costs and improve patient outcomes by having a vaccine. There was a question about why symptoms worsen at night, and that's a really interesting thought. I don't know if I know why specifically, like for sure, but if I had to guess, I think it would be something to do with one, their positioning, two, their environment. So one of the treatments for croup, which we can talk about, is like making sure that you have nice moist air, running a humidifier and things like that. So maybe like at nighttime, if it gets more dry, or if you're like laying down, and I don't know, those would be my guesses for why it's worse at night. But that's an interesting thought. And I think it probably has more to do with your environment and your like circumstance that you're in at night versus the virus like cranks up its severity at night. That's not really how it works.
So could it also be due to the fact of like the anatomy, like you're saying, the positioning of the body, but like the
Yeah.
lungs and the stuff closing, like maybe they have like some form of sleep apnea. They just don't know like the anatomy of the lungs or something can be closing.
Yeah, that's a very good thought. So I think like if it's an upper airway thing and you have maybe some collapse of the soft tissue, like the pharyngeal soft tissue that we were talking about before, that certainly could contribute to it. I don't know if any of this is actually evidence-based. Oh my gosh. So this is really interesting. Family member of, I think, is it Destiny? I hope I'm pronouncing your name correctly. Family member of them had croup, and the doctor said that it's worse because your body's natural steroid levels drop at night. So that would make perfect sense, because then your inflammation goes up at night. And that actually is true. Like when we test steroid levels for things like adrenal disease, we have to get like a morning urine sample because that's when it's going to be the lowest amount. So that's actually that explanation tracks really well. So thank you for suggesting that, because I don't think I would have come up with that on my own. Very interesting. Okay, so then the last thing that we wanted to make sure we ruled out was epiglottitis. And we're pretty sure that our patient doesn't have this because, they tested positive for parainfluenza virus and they didn't have any signs of bacterial illness on their labs. But again, this is something caused by Haemophilus influenza, which is a gram-negative bacteria. And that is one of the ones that we routinely will vaccinate against. So we more so worry about this in kids who are unvaccinated. And this is going to cause specifically local inflammation of the epiglottis. So unlike the other ones where we have viral illnesses and more diffuse and like more chill inflammation, this is like a really angry, like specific one location of the epiglottis, which can cause that airway obstruction. So that's why we want to be prepared to either intubate, or if we can't intubate, if they're already too swollen, then we might even have to get a surgical airway or do like a cricothyrotomy, which is basically cutting a hole in the trachea and inserting a tube through the skin so that they can have a breathing tube. So that's like,
do those ever go away? I've seen patients like in the nursing home and stuff that was trached and stuff, but do like those holes ever close or something?
yeah, so a lot of them can, if they're just temporary airways to help and wait for the swelling to go down. They certainly, and that's, I think, always the goal, is to be able to have people not be dependent on a trach for their breathing. It just depends on the cause. So people in nursing homes, especially old people, if they have any history of like dysphagia or trouble swallowing, it might be dangerous for them to rely on their own personal anatomic airway if they don't have like either the nervous system support or the correct anatomy to allow that to work. And it's actually safer for them to just have a permanent trach. But especially in kids who, if it's because of an infection, I would say that the goal is always to, and most times they're able to repair the cricothyrotomy and allow them to continue breathing with their own anatomic airway. And because this is bacterial, we want to make sure we include broad spectrum antibiotics with gram-negative coverage in our treatment for this. So number one, secure the airway. Number two, we treat the cause. So that'd be treating the infection with antibiotics. And as promised, I'm going to show a video of, this is a video laryngoscopy. So this is where you take the little camera and look in the airway. And there's not really like any sound that you need to listen to. So I'll narrate it, I suppose. If you see this, like that little hole that's right there, that's the whole airway. And then the epiglottis is this really giant red looking thing. And this is like as far open as it can get. And also this isn't an adult and not a child who has a lot more control over their breathing and their muscles of respiration. And even though it doesn't look so bad, like maybe you're like, oh, there's plenty of room in there, it can continue to get worse. And sometimes kids, even in the span of hours, can deteriorate because it just progresses so much faster than a virus does. So if you have a kid who comes in, they're unvaccinated, and it's like in a matter of hours that they've gone from like totally fine to they're in this tripod position, which was the other thing I wanted to point out. You see they're kind of like leaning forward and supporting themselves with their hands and like leaning their head out. That's to help try to open up that airway even more. And it can sometimes provide symptomatic relief for them, but it's not actually going to keep that airway open. So, yeah, that's just some red flags to look out for. Luckily, this isn't what our patient has, but it's always something that we don't want to miss. All right, we're almost done. Just wanted to check in, see how things are going. Do we want to go back to any of the pathology slides? Otherwise, we're going to move on to like the treatment stuff. And I know it's like already almost 9, so we'll try to move through this quickly. Okay, so I just wanted to break down kind of how there, with all things in health, there's always almost like a spectrum of how bad things can be. So for a mild case of croup, this might just be somebody who comes in with like basically just a cold. They might have a little bit of a cough and they come into your clinic and you just, don't have to do anything. You can send them home and do symptomatic care. Symptomatic care is always going to be a part of every stage and every severity. It just, the more severe ones, in addition to symptomatic or supportive care, are going to have more intervention. So for mild, you'll just do symptomatic care, and that's encouraging good fluid intake to prevent dehydration, encouraging lots of rest, taking medicines to help relieve pain like Tylenol or Advil / NSAIDs, Motrin, stuff like that, using a cool mist humidifier at night. just things that will help them feel better, but it's not actually going to do anything to clear the infection faster. For a more moderate case of croup, and the lines between moderate and severe, like here, they're not like super clear cut. It just, again, has to be your own personal judgment as a clinician. So that's where you can give this single dose of the corticosteroid shot, which is the dexamethasone. On your pediatrics rotation when you're in medical school, almost guaranteed you'll see somebody come in with croup, and they can just give this shot while they're in the office and then just have them go home. If you're more concerned about their respiratory status or their airway status, maybe they come to the emergency room at nighttime, their parents like freaking out, or the kids just like not looking good, then of course you can admit them to the hospital. You can give them the supportive care. You can give them the steroid shot, and you can do that nebulized racemic epinephrine, which I'll go on the next slide and talk about. And then, of course, if they need additional airway support, so like giving supplemental oxygen, or I'd say in croup, it's very rare, but like if they did need to be intubated, then of course you would do that. So just the mechanism for these drugs that we're giving, again, I kind of talked about this before, but the corticosteroid or the dexamethasone is going to help reduce the inflammation in the airway. And then the nebulized racemic epinephrine. So epinephrine is a very potent vasoconstrictor. So like I mentioned, the swelling comes from the vessels being really dilated and leaky so that the immune cells can get out of the blood and into the tissue. The epinephrine is going to counteract that. So it's going to cause localized, meaning only in the airway, not everywhere else in your body, that vasoconstriction to help close the blood vessels like tighter so that they're not leaking fluid everywhere. And that'll reduce the edema in the soft tissue. So that'll improve their pain, their cough, their stridor, just like a lot of the stuff can be improved with this. So those are the main interventions for croup. I always like to end these with a patient update. So our patient was discharged home after 6 hours of observation, and he's doing very well. And he's following up with his primary care pediatrician to be tested for asthma. Somebody's mentioned asthma at the beginning. And if you remember in our H&P, it sounds like they had some coughing before that was associated with playing outside in the cold and being around, I think, what was it, like cats or something? I don't remember what I said, but basically they were kind of like, I was trying to hint at some red flags for asthma, and it's okay if you didn't know that or if you didn't pick up on that. But basically, you know, they're going to follow up with their primary team and make sure that they can try to either prevent this from happening or just get on a treatment plan so that they can have better quality of breathing overall. And then somebody suggested this on my last virtual rounds, and I thought it was a great idea to include kind of what the path looks like to get to these specialties. So this was a pediatrics talk, and to become a pediatrician, you have to start with the 4 years of medical school, which presumably all of you want to do because you're here, and I think that's amazing. So in the US, that would be either an MD or a DO. And then for pediatrics, it's going to be a 3-year-long residency where you kind of get exposure to all the different specialties and the full scope of caring for children, basically ages from birth until 18 or 21 even sometimes. And then if you want to further subspecialize, then you can do fellowships like, for example, NICU, or which is neonatal or / neonatology. That's going to be like a 3-year-long fellowship. Pulmonary and critical care. So like if you want to be managing patients who are intubated in the ICU and taking care of really, really sick kids, then that would be another fellowship that you could do. Emergency medicine, specifically pediatric emergency medicine, is another fellowship option. That's usually like a 2-year one. And then if you exclusively want to work in a hospital and not just do clinic, then you can do like a hospitalist fellowship. So those are just a handful of them. There's so many that you can do. And you don't have to decide now. You don't have to decide now, even if you want to do pediatrics. Like I still don't know officially what I want to do. And I am having to apply to residency in like this year. So just take some time to explore your interests and learn about topics that you're interested in. I put this picture here of, this is actually Dr. Dickens. He works at the Stead Family Children's Hospital, which is the one affiliated with University of Iowa, where I am doing my training at. And he's a wonderful mentor. So I'm just encouraging you guys to find mentors and specialties that you'd like to try out, and just keep coming to these virtual rounds and see some topics that you might be interested in, and maybe keep like a journal or something of the ones that you like.
So do you have any favorites so far? Like, I know you said you're still trying to figure it out, but like, like anything that you're going towards? Like, I know you said earlier anesthesiology a little bit.
Yeah. So I'm currently on a general surgery rotation,
Mhm.
which is why I was a little late today. I really love the OR.
Right.
Yeah. So I'd say I'm most between either anesthesia or general surgery, but I also loved pediatrics and I loved NICU, which was why I did the neonatal physiology virtual rounds. And if you guys haven't seen it, I think it's on YouTube already, so you can go watch it.
So couldn't you combine it as a pediatric GI specialist, like primary for like pediatrics, but GI?
Yeah, so that would be doing a pediatrics residency, and then GI is one of these fellowships. I just didn't list it here because I was running out of space on the slide, but they have peds cardiology and GI and allergy immunology and all these other ones, and you could probably find a list online, but literally like anything you can think of.
Mhm.
Okay, guys, so that's all. I know we were just a couple minutes over time, but if you'd like to get that certificate of completion, then you can start on that quiz. If you'd like, I can go back to any of the slides for you to fill in gaps on your note or to refresh your memory on something if you're struggling with a question. And yeah, just thank you so much for joining. I really, really love doing these, and I'm so happy that people were active and asking questions and being in the chat and everything. So keep up the good work, and I'll be around until the last person logs off. So if you like to ask any other questions about medical school or anything, then just please let me know. I've got the rest of the night free.